My name is Dr. Michelle Williams. I'm the Chief Medical Officer at Matthew Walker Comprehensive Health Center here in Nashville. And that's it, name and where we work. Okay, and what I'm going to be presenting is the Community Health Grant Opportunity Proposal for addressing the social determinants of health in the chronically ill adults. And it's going to also be advancing health equity among those people with chronically ill diseases. Just a little bit about Matthew Walker. We're actually celebrating our 50th year anniversary. We have a breakfast if y'all want to come in a couple of weeks. I think the 12th at 7:30. But we're celebrating our 50th anniversary. We have a site here, and we also have a site in Smyrna and Clarksville. We have probably about 53% uninsured population, and of course, you know, we have TennCare, commercial, small amount of Medicare too. But we provide care to, we always say, from the cradle to the grave. I'm a pediatrician by trade, so we see the patients in the hospital, General Hospital, newborns, and we also see we have internal medicine, we do geriatric care, family doctors, obstetrics and gynecology, and we also have on site in Nashville a pharmacy, and we have 340B pharmacy, and we also have dental clinic too. And then we have like a case coordination, patient-centered medical home case coordinating team that we started with the state PCMH program, patient-centered medical home program. I'm trying not to use acronyms. And so we're kind of comprehensive. We also have radiology on site. We do plain films and mammograms, screening mammograms also. So kind of comprehensive. So what we wanted to do is, as far as to improve the health of the chronically ill patients, such as our hypertension and diabetics, is to assess the social determinants of health and addressing the patients in their environment. Kind of that nurse that comes to the house, or that nurse practitioner that comes to the house, that we kind of used to do. And actually, if you have insurance, a lot of insurance can do that and then get, you know, care partners. But if, like I said, we're 53% uninsured, so you're not going to have insurance to do that. So we wanted to kind of invest in these type of services: nutrition, health education, behavioral health, and medication management, and address them in the patient's environment. We have over 2,300 hypertensive patients. Also, we have about over 1,000 diabetics, with roughly 50% and a little less of 40% of diabetics being in control, meaning blood pressure is less than 140/90, and their hemoglobin A1C is less than 90. And so we wanted to look at those two chronic health conditions and try to decrease that hospitalization and ER utilizations also. And what we were going to do first is utilize the protocol for responding and assessing patients' assets, risks, and experiences, prepare to evaluate the patient's social determinant of health. And once we've done that, we would have a home visiting care model where we would have the team lead would be a nurse practitioner, and of course backed up by a medical doctor, and bring in the nutritionist so you could better explain and be in their environment to see what they're cooking with, what they're utilizing. Also to have the educator there so you can explain, you know, how to take their medications and do more medication therapy management on site. And of course behavioral health, because a lot of times these patients, their hemoglobin A1C is up and they think they're doing everything to get better, and so when they come to the doctor we say it's not, and so they get depressed, and so it's just that vicious cycle. You know, you think you're doing better but you're not, and then because you're not getting better you're depressed too, so that just kind of works both ends. And we would do that. So we would also describe what we would do as far as the first thing is to do the fact finding and get our team together, which will be led by a social worker, and the team would get together and create our job descriptions, our policies, our procedures, and our outreach, because we've done outreach where we do outreach at health fairs, but not outreach is outreach in the home. So just to get those policy and procedures together. And then we would also look at screen our diabetics and our hypertension using the Prepare to and see what it is that they need, if it's transportation, if it's nutrition, if it's whatever they need. And that would be the second part of the program. And then we would serve these individuals. We're Joint Commission credited, and we also are accredited patient-centered medical home certified through Joint Commission, and through the state we're going to be doing the NCQA Joint Commission medical home certification. And so we kind of have a lot of the quality is already set up, and also being a federally qualified health center, we already have kind of like our board, our continuous quality improvement plan together, and all of these kind of fall right into play, so everybody's doing the same thing and not duplicating. And so we would be monitoring those patients, trying to get at least 250 patients, if not more, and compare those with those that are not in the program to look and see. And we can, you have your hemoglobin A1C and your blood pressure. And also we'll use like I'm trying not to use PHQ, not the depression screening score, to also look at the behavioral health component to see, if they're depressed or not depressed or doing better. And we would have, like I said, our behavioral health that'll be there on site, and also just to be counseling in general. And this would be our, we're asking for the grant to develop this home visiting program, especially to serve our uninsured population here.